إزاي الصحة؟ تطوير أي منظومة طبية بيعتمد في الأساس على تدريب الكوادر الطبية وتعزيز التعاون ما بين الأطباء. وعلى المستوى الإفريقي، نجاح أي منظومة هيتم من خلال التعاون ما بين الباحثين والعلماء على مستوى الدول الإفريقية المختلفة. ضيفتنا النهاردة واحدة من أهم أساتذة الأمراض الكبدية في جنوب أفريقيا. هنتكلم معاها على فرص التعاون ما بين مصر وجنوب أفريقيا، وكذلك التعاون على مستوى الدول الإفريقية لتدريب الكوادر ومواجهة الأمراض زي فيروس سي وغيرها من الأمراض الكبدية. Professor Wendy Spearman, thank you for joining us.
Thank you for having me.
Thank you. It's an honor to have you with us in the show. And I had the chance to read your resume and lots of interesting and great achievements. So let's start first with you as an emeritus professor of hepatology. Why were you interested in this field specifically?
So when I was a registrar, in fact, towards the end of my training, we did the first liver transplant in South Africa. And for me, that was incredibly exciting. And I just felt this is something I wanted to do. But obviously, as you grow into the discipline, you realize that the burden of disease within Africa and in South Africa as well is really significant. And very importantly, it's under-recognized. So disciplines like cardiology, respiratory, renal medicine, they're very well established. But liver disease as a discipline is really not well established. And so there really was this opportunity to really help a number of people within the country. In fact, we're only 3 hepatologists in South Africa. So 3 hepatologists.
You're talking nowadays? Or
No, we're only 3 accredited hepatologists. And so our discipline has only really been recognized about 4 years ago as an independent discipline. So we've been really working very hard to establish this as its own discipline and be able to attract youngsters to train in liver disease and provide care.
Do you have an explanation why other doctors were not interested in hepatology?
So, I mean, one of the things with hepatology is that you need to enjoy clinical general medicine. And you need to, it's quite an intensive discipline in that patients are often very sick. They're often with you for a long period of time. Patients, unfortunately, particularly in the early days where there was limited medications, really died as a result of complications of liver disease. And then it's often not a procedure-driven discipline. So, often people prefer to have disciplines that are procedure-driven. But I think particularly hepatitis C put hepatology on the map in terms of what can be achieved with identifying individuals, getting them onto treatment, linking them to care. And so I think this is an area that's going to be growing, particularly hepatitis B, and we now have the problems of metabolic dysfunction associated with steatotic liver disease, which is really associated with the rising prevalence of obesity and diabetes. So it's going to become something that the general healthcare worker will know something about, but we need to educate them.
This year you received the Ezzay Award, and you and Professor Manal Hamdi Sayed. And as far as I know, you were both the first non-European, non-Americans to be awarded by the Ezzay. Would you tell us a bit about this?
Yes, it really was a great honor to receive this jointly with Professor Elseha. I mean, we've, I think, known one another now since 2018. And I think our vision really is very similar to actually reach the individuals who require treatment and educate and link clinicians and researchers across sub-Saharan Africa. So for both of us, it was really recognition of our education programs, our outreach programs throughout Africa. So one of the important outreach programs that we run from our liver clinic at Groote Hospital is Project Echo. And Project Echo is a telehealth, telementoring program where we have an expert hub within our own liver clinic, and then we interact with countries across sub-Saharan Africa. We present difficult cases of hepatitis B or C or liver cancer. And then as a team, we discuss, and we usually start with a very short 15-minute didactic lecture. And what we try and do is link that to the cases that are being presented. So you give education, you have interaction, and as a team, we actually make a collective decision on how you actually can manage these patients. And the really exciting thing about Project Echo is that not only do the community we are presenting learn, but we as the experts actually learn, because you need to have to adapt to what the resources are within different regions. So it's really a great learning experience for all of us. And so we've been involved in these Project ECHO programs. We've also been involved initially before COLD and SOLDA with the Gastrohepatology Association of Southern Africa, which also looked at outreach programs, trying to improve knowledge around liver disease throughout Africa. And so I think it was really a combination, and then COLDA, and then culminating in the development of SOLDA, which really gave us recognition, I think, of actually bringing Africa onto the stage.
Let's talk first about the ECHO program. How it was brought first? Was it based on the country's demand, the doctor's demand, and who were included aside the physicians?
Yes. So, I mean, Project ECHO was founded by Sanjeev Arora, who was a gastroenterologist working in Albuquerque, New Mexico. And he started it because he realized that New Mexico is very similar to many countries in Africa, with a very small number of expert centers, but a large demand and burden of disease. And so he developed this to actually deliver hepatitis C therapy. And this was in the days when we were using pegylated interferon, which was really quite difficult to implement. And so managed to actually increase the access to therapy across New Mexico. And that's now been expanded across the world. So I first heard about it in 2016 when Dr. Arora gave a plenary lecture at the American Society for Liver Disease meeting. And the first thing I kind of realized, this was something that would be very relevant to Africa, not only in terms of liver disease, but management of hypertension, diabetes. So it has really quite significant applications. And so we started in 2018.
Online courses.
So it's a telehealth, telementoring system. Okay. So you can do it in different ways. You can decide you want to develop a training curriculum in hepatitis C, or training curriculum in hepatitis B, or MASLD, whatever you'd like to consider. And that's very appropriate if you're using it at community level. Our Project ECHO is slightly different in that we're involving gastroenterologists, hepatologists, and they're bringing to us very complex cases of hepatitis B and C, but sometimes don't have all the resources that we might have in a well-resourced country such as South Africa or Egypt. And so we work out ways how to actually manage these complex cases. And so what we will usually have is a 15-minute didactic lecture around a particular problem that's going to be presented to us. So we started off with our hub is the expert hub at the Liver Clinic at Kruderskeer, and then we started off with 4 countries, Ghana, Ethiopia, Nigeria, and then supported by Professor Jeff Dusheka from University College London. And those were our initial spokes. And subsequent, we've actually expanded to at least about 30 countries across sub-Saharan Africa. 30 countries, yes. And so they will all come online, they will present cases, and we've now expanded it so that every quarter we have a 1-hour program, that 1-hour sort of slot that's just dedicated to managing complicated liver cancer cases.
Were you able to measure the impact of these telemedicine?
Yes, so that's a very important thing. So initially, it was really looking at how many of the participants came back and continued to present cases. I mean, at the moment, if we look at the number of participants that we've probably reached, it's probably about 12,000 that regularly come back, and so that's really quite a significant impact. In terms of we're looking now, trying to have more objective measures in terms of outreach, in terms of how many people are being trained. But I think that's something that we need to be looking for in the future. We've also used that Project ECHO program to train fellows. So we have a weekly program where fellows who are about to do the examinations actually present cases or present topics, and then they get interactions from the consultants.
Who aside of the medical doctors, who are the other stakeholders who were included to boost this program?
Yes, so the important thing obviously is to involve midwives as well, particularly in hepatitis B. So we've involved them. The next thing would obviously to involve obstetricians as well. So this can be expanded very, very rapidly. Yeah.
And the policymakers of these countries, were they included
to
raise awareness about?
So we haven't. I mean, that's a very good question, because in fact, if we look at the Project ECHO program, where it's been very successful is actually in countries like Namibia and Zambia, where they've used it to roll out HIV programs, and there their ministries of health have been actually actively involved. We didn't take that approach, but in terms of South Africa, our Dr. Vilakazi Khomotso, she actually often comes onto our program. She is the lead director for the viral hepatitis, HIV and TB portfolio. So she regularly joins our programs as well. But you're absolutely right. That's a way one could actually increase the access and knowledge of our ministries of health around liver disease.
They always talk about viral hepatitis diseases, that they are silent diseases.
Yes.
And in absence of data, screening programs, there is less to do.
Absolutely.
So was that, how have you been thinking or working on that challenge, for example?
So, I mean, you're absolutely right. If you don't have the data, you don't have power to actually change policy. One of the problems is that doing seroprevalence studies are actually quite expensive. If we look at the cost of diagnostics, and that's one of the problems in managing viral hepatitis, is the cost of diagnostics, particularly for hepatitis B and monitoring, far exceeds 1 year of therapy. So tenofovir for a year of therapy is only $32, and yet you can look at the cost of doing a hepatitis B DNA level, which can range anything from $12 to $100 depending on where you are. So importantly, we need to look at those costs of diagnostics.
There had been, aside of that, you have mentioned as well the conference of liver disease in Africa, and you're the vice president of...
Yes, so absolutely. So we started doing these conferences on liver disease in 2019. And the whole aim of that was to actually have representation across Africa. So the international meetings are fantastic, and you learn an immense amount, but in fact, it doesn't give a voice to clinicians, researchers within Africa. And so one of the real reasons to actually start Calder was to actually have a platform where young researchers, clinicians could actually present their work, and actually have expertise from Africa giving plenary talks. And so we started off just with the conference, and then we realized that, in fact, you needed a society as well. So the society is very young, really only started at the end of 2022.
Which is the SOLDA.
This is SOLDA, the society. Okay. So that grew out of Calder, recognizing that we needed a more formal collaboration and a society that people within Africa could actually join. Obviously, it's open to everyone, but we wanted a society that could be owned by researchers, clinicians within Africa. And so that's really grown. I think we now have over 1,000 participants as members of SOLDA, and importantly, it actually represents all 5 regions of Africa, so North, South, Southern Africa, East, West, and Central Africa. And I think that's very important because people often think of Africa as being a homogeneous region, but in fact, they're different diseases that are more prevalent in different areas, different challenges that they might face, although they are very similar. But I think it is very important that one has representation. And so in our board, we really try to ensure that we have representation from all 5 regions of Africa.
Do you have like a process to harmonize the educational programs across the different regions and the countries? Because when I'm listening to you, I'm thinking about the different medical standards in each country, the lack of infrastructure or training. How have you been tackling this issue?
One of the big things, as you mentioned earlier, if you don't have data, then you don't have the power to actually, influence policy. And so one of the big sort of hurdles is actually how do you capture appropriate data? And so one of the series of webinars that we're wanting to plan starting next year is actually having training programs on what is the minimum data that you need to capture, what's the best way of actually capturing it, and how you utilize those data. And so we've been in communication with Dr. Homi Razavi from the Polaris Observatory Centre for Disease Analysis, who's been very helpful in actually suggesting webinars that we could hold and potentially driving those webinars. And we've had quite close interactions with the Polaris. They've been very active in actually assessing disease burdens across Africa. And so it's important to utilize information and collaborations that are out there. So those are one of the collaborations that we want to be more actively involved. I mean, we've been very lucky that we're now a sister society of EASL, ASLD, and ALE and APASL. And one of the benefits of that is that you potentially can share training curriculums. And we've just been told today that EASL is actually allowed for SOLDA members to actually have free registration to EASL, which is really quite fantastic, because then you have access to all those curriculum resources. From our own point of view, I think what we really see is that we need to improve research, the ability to actually, so as you know, Africa has a wealth of clinical knowledge, but if we look at the number of publications, that they are lagging behind the wealth of public knowledge that we have. So data capture is a very important component of that. And so, I mean, there are a number of collaborations that we have with HepsNet, which is the hepatitis B network across Africa. And we now, I think, 12 countries, 12 to 15 countries, looking at hepatitis B and capturing data on longitudinal data, so that you can have outcomes, long-term outcomes. And so those sort of collaborations are extremely important, because in fact they do influence policy. If we look at the HepsNet, that actually enabled, we recognize that the APRI score, which is a score determining fibrosis and the risk of cirrhosis, the original one from the WHO in 2015 was set too high, and it actually missed 50% of cirrhotics in Ethiopia. And that grew out, the HepsNet group grew out of a meeting in Calder in 2019, where data was being presented, and we realized that there wasn't much from Africa. And so we now have data on over 4,000 patients, once-off data, but we're now collecting longitudinal data to actually see outcomes. And that'll be very important in terms of hepatitis B.
You say 4,000 from which country?
So across 12 countries.
4,000?
4,000 documented patients of hepatitis B. Okay. And looking at those, how they presented, what their lab data were, we were able to actually recognize that the scoring for fibrosis was set too high by WHO initially in 2015, needed to be much lower, and that influenced the new 2024 guidelines, where they really lowered the APRI scoring from greater than 2 to greater than 0.5. And that was really influenced by having data from Africa, and really shows the power of having appropriate data. And what we're wanting to now show is that if you have longitudinal data, so one of the problems in Africa is that often the viral load is not very high, it's low, but yet you have very young individuals presenting with liver cancer. And so we want to, with this longitudinal data, actually try and move in the centers that we are now part of this group. Every patient that we have with hepatitis B gets entered, and every entry point into the system then gets entered as well. So we'll have very good long-term data, and that will help to drive policy in terms of, are the initiation criteria for treatment still the correct criteria? Do we need to bring it in earlier? What are the risk factors for cirrhosis and liver cancer?
Aside of the academia and the doctors and the policymakers, I have noticed that there are other players that, yes, like international organization, yes, the CDC Africa. Why do you need these organizations in the research work and the networking associations? And what kind of role do they play vis-a-vis the important research work that you have been highlighting?
Absolutely. So I think, obviously clinicians, researchers are very important to actually establishing the data, but you need to have access to ministries of health, politicians, and often clinicians don't have that direct access. So very importantly, things like CDC Africa, the African Union are very important, because they are operating at the level where they interact with ministries of health, interact with parliamentarians, and I think that's very important, that they actually almost our voice to actually get that entry into ministries of health, so we can actually implement policy. And so and the other group that we really need to remember is the patient advocacy groups, because really what one's actually increasingly realize that, in fact, it's always that patient who actually should be center and should have a major voice in determining how you actually get diagnosed, how you get treated, how you get managed. And so that's one of the real sort of strengths, I think, of our SOLDA and COLDA meetings, if they have a very powerful voice within our community in terms of actually addressing what the problems is, what we sort of holding us as clinicians to account and researchers to account, that we need to put the patient center stage. And so CDC Africa, we actually now involved together with HepSanet in actually looking at developing implementation delivery models for hepatitis B. So you can have fantastic guidelines. And we know we've had the international guidelines, we've had the previous WHO 2015 guidelines, and yet less than 15% have been diagnosed, less than 5% have been treated. So you have fantastic guidelines, and the new guidelines are very good in that they actually increase the access to therapy by about 50%. But we still need to get that to ground level. So what we're looking at now, together with HepSanet and CDC, working as a team to really look at how we can actually develop implementation models. And I think probably Professor Easterbrook was very active in talking about implementation, because that's really where it's going to fall down. So we need to be practical as well.
With the budget constraints across African nations and the enthusiastic programs that you have been highlighting, how you as physician and through the networks, how you're able to keep on running these programs, networking, pushing forward things with limited budgets in the countries. And is there any recipe for getting funding and bring attention to these hot topics that you have mentioned?
Yeah, so I think, funding is always a big problem, and we have to compete with other diseases, particularly other infectious disease, TB, HIV, malaria, which historically have always got the international funding. And then obviously we have this rising problem of communicable diseases, which has a major impact on morbidity and mortality. So one's competing with all of those. So I think if we're going to be looking at being effective, we need to actually stop working in silos. You can't have communicable diseases, non-communicable disease, particularly at primary healthcare level. Obviously, as you get to tertiary, you're going to have highly specialized services. But primary and community, we need to look at integrating services. So integrating HIV services, integrating the clinics for chronic diseases. And I think that's how we're going to have to be more effective in managing patients. But once again, you can't just add on another disease entity to a clinic. So that needs to actually come with funding. And that's why we need the data to address ministries of health, so that although everybody wants to integrate, there has to be dedicated funding to that. The Global Fund now really has opening funding a bit more to viral hepatitis, which is very good. But I think very importantly is the Gavi Fund. The Gavi, which will support the birth dose vaccine.
Okay, the Gavi.
Yeah. Yes, that's very important. So that was put on hold during COVID, but then last year they recommitted to actually supporting low-income countries to apply for funding to roll out that birth dose vaccine. But countries need to actually apply for it. It isn't, Gavi's not going to come to you. You need to actually apply for it. And so we need to, and that's one of the things that, SOLDA can also be active in actually identifying, helping to identify how you actually apply for these type of funds, because otherwise, the applications are they're quite intensive, and so one needs training in how to actually apply for these appropriate funds.
So when the process of applying is per country, not per networking.
It's per country.
It's per country, and every country is responsible of collecting the needed funds to do the research.
So they would need to apply individually for these fundings, put forward proposals. Obviously, things like the Global Fund, if you've got crossing different countries with a similar program, that's got obviously more power. But those will be for specific projects. With the Gavi funding is for individual countries. But that, I think, is going to make a major difference. If you think within the WHO Africa region, there's only 15 countries that have implemented that birth dose vaccine, and only 18% give it within 24 hours. So, and that is really, I think, if we're looking at eliminating hepatitis B, where we need to be concentrating, because basically you identify the pregnant woman who's positive, You get her into treatment to prevent ongoing transmission to the baby gets vaccinated at birth. But very importantly, that's a point of entry to screening the partner, the siblings, the other children, because we know particularly in hepatitis B, many people within the same family will be hepatitis B positive, and also if there's any family history of early cirrhosis or liver cancer, they're at greater risk. So this is a very important way of breaking cycles of infection, and it's probably a more cost-effective way of screening than doing mass screening, which can be very, very expensive.
It's quite known in other diseases that there is lots of philanthropists and international donors who have been supporting certain health programs, malaria, HIV, through the regional and African networks. Was that on the radar of bringing them and bringing Hep C and Hep C?
So I mean, in terms of the international funding, it really has been concentrated in TB, HIV, and malaria. Viral hepatitis hasn't really been on the radar. But I think once again, we need to have a more active voice, and we need data to actually show the burden of disease to really, because if you look at successful programs, they've had domestic funding, but also often catalytic funding from outside as well to get things going.
Professor Spearman, you have mentioned that in a previous interview with you that in across Africa there is what we call the champion countries in the healthcare service, and especially in the field of hepatology. Would you elaborate on that, please?
Yes, absolutely. I mean, within Africa, we always look to the West, we look to Europe, we look to the States, we look to the United Kingdom. But I think we need to realize within our own continent, we have really champion countries who've made major strides in actually overcoming and eliminating viral hepatitis. And obviously Egypt is, the top leader in terms of hepatitis C, actually acquired the gold tier status from WHO for elimination of viral hepatitis. But I think, and then we've got Rwanda, who really has been leading the way as well in terms of hepatitis C, and now hepatitis B. And then Namibia, I mean, I think for Rwanda, they expect to eliminate hepatitis C by this year. And for Namibia, which is a small country, have actually been recently awarded the silver tier status for the elimination of mother-to-child transmission of HIV, and the bronze tier for mother-to-child transmission of hepatitis B. So these are two small countries, and then Egypt, which really led the way. But if you look at what has been key to the success of the champion countries is the political commitment, recognizing that there's a burden of disease, but also providing the appropriate financing. And without those two components, it doesn't matter how good your guidelines are, you're not going to achieve anything. And the other thing I think that has been really key to all of them is actually task shifting, moving care for viral hepatitis from the specialists to primary health care. And very importantly is also having clear pathways of linkage to care. So if you've got a complicated case, you get referred upwards, and having that clear pathway, knowing what to do if you have complex cases. So, and really key to also that is education. Educating the healthcare workers at all levels of what viral hepatitis is, how you diagnose it, how you treat it, how you link it to care, how you follow it up. So I think in all three countries, there's been those sort of key components: political commitment, dedicated funding, education, and task sharing, involving the nurses, community healthcare workers in the management, and having a direct interaction, an equal interaction between all healthcare workers. I think that is key.
Good. And based on that, how could we strengthen the South-South collaboration in sharing experiences, models of best practices? Is that possible to be done across African countries?
Absolutely. So I think, that's one of the sort of roles of CDC Africa is actually to link different countries, help address programs. And in fact, I think they're bringing to Egypt now, they mentioned 10 countries, representatives from 10 countries to actually learn in terms of hepatitis C elimination practices. And so I think it's really important that, because each country with their elimination programs have individual challenges, barriers that they've actually addressed that actually might be amenable to other countries. So I think what it really shows that you have to have interaction, you have to have dialogue between the different countries. And so we need to learn from one another. Just like in Project ECHO, we learn from one another. We need to have these dialogues. And that's one of the big sort of benefits of COLDA, is the interaction between these different regions within Africa, with key leaders actually presenting work, presenting how they've actually approached problems, how they've addressed problems, and where they're struggling with problems.
Let me focus on the Egyptian-South African relations in the medical research field and as well in enhancing the healthcare services. Are there any programs that have been running for the past few years of collaboration across these two countries, knowing the high caliber of scientists here and there, and the networking collaborations across both research institutions and scientists in both countries?
So between Egypt and South Africa, we've always had a strong collaboration on liver disease. I mean, particularly in terms of liver transplantation, we're probably the only two countries which have active liver transplant programs. There are a number of countries within Sub-Saharan Africa which are starting programs, and in North Africa, but we're probably the only two countries have the active programs. And so we have a lot in common. We've had interactions. In fact, we had in the sort of 1990s, we've had an African Association of Liver Disease where Egypt and South Africa were sort of the main components. And the reason that actually broke down, I think, is that we didn't have enough representation across Africa. And that's really the benefits of SOLDA. So there's been a long history of collaboration between Egypt and Africa, between academia, and we have very close interactions with our hepatology colleagues within Egypt. It's really been strengthened by SOLDA and COLDA, and particularly Professor Manuel Al-Sayed was really been very instrumental in actually linking and networking colleagues within Egypt with South Africa, but also across Africa.
Mm-hmm. And so based on this strong collaboration and the presidency of COLDA and the launch of SOLDA a couple of years ago, if I'm not mistaken, who else should be included in this strong network of physicians to boost things forward and to empower the projects that we have been talking about?
Absolutely. So, I mean, we've been very fortunate. We're now a sister society with ASLD, the American Society, the European Society, the Latin America, and Asia Pacific. And so they've been very generous in sharing their knowledge, how you actually sustain societies, because societies can come and go. It's very important that you have sustainability. So they've been very supportive in actually potentially sharing education programs. I think it's important, though, that we recognize that within Africa, there are a number of centers of excellence. One of the big concerns that we have is that very few clinical trials have been done in Africa. Obviously, Egypt has led the way in terms of hepatitis C. South Africa have had a number of hepatitis C trials and some hepatitis B trials in early phases, but we're really lagging behind in access to clinical trials. And so one of the things that we want to do is really have a registry of the centers of clinical excellence, and those identify individuals within those centers that actually can take on clinical trials. And I think, we had a presentation yesterday in terms of clinical trials, and there's really now an understanding that the burden of disease is within Africa, and so you can't leave Africa behind. It's no use having functional, clinical trials and functional cures for hepatitis B with the burden of disease in Africa and you're ignoring it as a continent. So I think there is a recognition and increasingly support for us to be part of clinical trials, both research trials and treatment trials. So I think that sort of narrative is changing, but we need to actually, it's always important that you actually take responsibility yourself, as a country, as a center. And so we need to actually get our own house in order, actually show what we are capable of doing, what we actually can deliver as well. So it is a two-way process always. Yeah.
One of the challenging things of having a vivid program for clinical trials is to have a policy framework, and even to harmonize policy frameworks across the African countries to attract more funding for trials and international pharma companies to support and boost this. have you revised this challenging
it is
process?
So it is a challenge. So I mean, one of the things, obviously, any trial, whether it's research or clinical, needs to go through an ethics board, and so I mean, obviously, South Africa has very strong, long-standing history of having a very strong ethics boards across in different disciplines, but they are looking at having a more central ethics regulatory system for Africa, which will make...
For all Africa.
Yeah, that's one of the things that's been looked into, which will make really access to clinical trials probably a little bit easier. But I think that's going to be a while in coming into fruition. But we know, I mean, if you just look at the HIV trials, the number of HIV trials that have been done in Africa, highly successful. There's no reason we can't translate that to trials for liver disease within Africa. And I think we need to remember that. But there's this big discrepancy between the successful HIV trials which were offered to Africa as opposed to liver disease trials.
But who should be leading this and solving this problem?
Yeah, so I mean...
A unified...
No, absolutely. So, I mean, one of the things that we're looking at in terms of SOLDA is actually having a registry of, across Africa, centers of excellence that are able to actually conduct trials. And then potentially individuals, companies that are pharma or industry that are interested in conducting a trial would actually have this registry of centers that actually are able to actually conduct trials. So we're thinking of actually putting that into place.
Okay. During your talk, you mentioned the patient associations, patient rights associations. Why they should be included in the ongoing research, and how do you include them in the tailing programs research, and how far were you able as the COLDA to listen to their concerns, questions, because in the continent there is lots of misleading information that is circulating about lots of things, about the diseases, treatments, and all that.
So, I mean, I think that's been one of the strengths of COLDA. Right from the very beginning, we actually included the patient voice and community representation. So the World Hepatitis Alliance has always been a very strong partner for COLDA and SOLDA, but we also had representation from other patient groups across Africa. So in Nigeria, we've had the Live Well initiative run by Busy Bright. We've had Danduma and Adder's Foundation. We've had the number of representation of community representation from Uganda. And so we've had very strong representation right from the very beginning. And we always have a dedicated session for the community voice within our COLDA meetings. And I think it's extremely important. They hold us accountable. They make sure that we actually are remembering that the patient is centered to everything. But that has been one of our strengths. One of our strengths in COLDA is that because it's still a small, it's not a massive meeting like thousands like you will see for EASL or ASLD, is that within the same room we have researchers, we have clinicians, we have the community voice, and that's very unique in the meeting, and it brings a certain energy to the meeting and accountability to both for the clinicians and researchers. So it's really quite a dynamic component of our meeting, which we really don't want to lose.
As an international community, what were the lessons learned from COVID pandemic, from your perspective?
Yeah, I mean, we always hear about the problems associated with COVID, and I think that is real. Before I go on to the benefits, I mean, obviously there's a breakdown in immunization services and particularly the long-term care and surveillance for liver cancer in patients with liver disease. And so we are going to see those effects down the line. And we know from our own clinic, if you look at, particularly we've been entering the database now of all our patients, and we can see this breakdown in patients coming between 2018 and then suddenly disappearing. So those are lost patients that we need to address. But I think we need to really think about what we can learn from COVID. And if you think about in a short period of time, we were able to roll out screening with PCRs. And PCRs are a big limiting factor to actually identify active infection within hepatitis B and C, the degree of activity. And yet we can't do that for B and C across most of Africa. It's too costly. But for COVID, we could run it, roll it out very, very quickly. And I think you need to remember that we have the platforms to do that because, in fact, we use the same machine to measure for HIV, TB. So those machines are available. And importantly, at community primary care level, they know how to utilize those diagnostics. Then the other thing that was really very effective was the use of the community healthcare worker in order to educate patients around COVID and also to contact trace. And that is what we actually need for hepatitis B, for hepatitis C, and particularly for hepatitis B, is actually to identify, to use those community healthcare workers to identify, to educate, and also use the language that can be understood, understanding the cultural situation, the economic situation within their communities, and what is the best language to utilize. And so we learned very rapidly in how to actually roll out these programs during COVID, but we seem to have then not utilized that, taken that forward to use for hepatitis B, particularly within Africa, which I think really would make a big difference because the barrier is the diagnosis. The barrier is that access to actually identifying the degree of viremia. And so we should be able to demand from industry that the viral load testing is at an affordable level, like we could do for the COVID PCR. So there's lots that we can learn from COVID, and we need to make sure that we actually continue to implement those procedures that were highly effective during COVID.
Yeah. Every now and then there is popping news about the new technologies, solutions that would revolutionize the healthcare service, would enhance the access to treatments, better management of data. How far do you think that this could be applicable in low middle income countries?
So, I mean, there's obviously definitely a place for AI and use of big data. We do need to remember the access to data and wavelength within Africa. I mean, we often find the problem when just in terms of Project Echo, stability of the network. So we need to remember things like that. But I think obviously we need to increase telehealth, telementoring, and getting that out. But in terms of AI, where it actually can be really very useful is in terms of pathology. So if you have liver biopsies, we often don't have very many trained expert pathologists in liver disease. And that's where AI can be utilized. But also importantly, it can be utilized to actually pick up early liver lesions on ultrasound, or actually identify worrying, concerning lesions on ultrasound or on CT scan. And so that will be highly effective, particularly in a region where liver cancer is a major problem and tends to present late. I think just being more practical is that how can we improve the knowledge of healthcare workers identifying those individuals who are at risk of fibrosis and cirrhosis and need to be referred upwards. And so very similarly to how if you order a blood test to check your cholesterol profile, or you order a blood test to check your glucose or your creatinine, you will get an automated reading at the end of that result saying, this is what your cardiovascular risk is. This is at the stage of your renal impairment. And so very easily we could actually have that. So in terms of assessing for early fibrosis, there's something called the FIB-4 score, and that takes into account the age, ALT level, the AST, and the platelet count. And so we frequently ask for those tests. And so what one could have is an automated calculation saying this patient has a FIB-4 score above a certain level, they need to be referred upwards. This is actually below a certain level, you don't have to worry for the next year or 2 years. And so those are very simple implementation.
Yeah, it could be automated.
Yeah, it can be automated. It's already been done in Scotland and been highly effective. And so that's a very simple maneuver that we could actually implement, which make a major difference, particularly if we're looking at in terms of patients with hepatitis B. So we now say if you've got a certain fibrosis score, doesn't matter what your level of activity is in terms of your ALT or DNA level, you will start on treatment.
Aren't you worried about the machine hallucination or possible errors that
Absolutely. And so that's an important question, because in reality, when you look at any investigation, there's always the responsibility of that clinician to look at, does this make sense? is this a complete outlier? Do you need to repeat it? So you can never take away the actual clinical interaction and interpreting results. And that's the important thing. When you have scoring systems, you need to know what underlies that scoring system. Why is that level? If that level is high, why does that imply there's more cirrhosis? So I always teach my registrars and fellows, scoring systems are fine, but you need to understand what makes up a scoring system, because then you will actually very quickly pick up that doesn't make sense. That FIB4, that scoring system is too high for what I've actually got. And I think, in terms of, I don't think AI is ever going to take the place of the clinician, because obviously you need to utilize it, how you can improve delivery of care, but the human interaction is very important, because if you lose that human interaction, you lose that patient voice, and the patient voice is extremely important in holding us accountable, holding policymakers accountable. So we need to utilize it in a way that can improve healthcare delivery to our patients, but not replace it.
My last question, great efforts that's happening now on the ground through the networking across African countries. What are the plans to move things forward, not just for the coming years, but many years to come, and how to build on the ongoing success and the strong networking across physicians and hepatologists?
So we look at sort of cold as shoulder. What we want to do is actually to improve. Firstly, we want to actually get clinical and basic research on the ground, get it, increase it. And one of the reasons is to have that registry, so that we know where the centers of excellence is, know where people are interested. We want to actually improve our involvement of junior clinicians within SOLDA. And one of the ways we want to do that is to improve our webinars, actually get them involved in actually presenting on these webinars, get them interacting with other networks. So one of the very encouraging things is the Barcelona Liver Clinic are quite interested in actually involving us, being involved in our society, but also providing sort of on-hand scholarships to attend liver clinics within Spain, to actually have hands-on experience in and actually get exposure to management of liver disease in another country. So I think we need to be looking at how we can actually develop scholarships. That's obviously going to require funding, and that we need partnerships in terms of pharma industry, potentially other universities looking at providing those scholarships. But I think what we want to do is, when we train young clinicians and researchers within Africa, we want to retrain them. We don't want to be training them so that they move out of Africa. And the importance for that is to actually really enhance the centers of excellence. So you have this expert training, but there's a place for you to remain within Africa. And that's what we want to try and actually enhance, the centers of excellence within Africa.
And to raise the standards of healthcare services across the different countries with respect to the challenging economic situation.
So I mean, I think when you in terms of raising healthcare services, that's obviously quite difficult as a society to address that. But I think if you raise the education and awareness of healthcare workers within a country, that enables them to put more demands on their ministries of health to actually fund better services. But you have to. It's very difficult as a society to influence individual countries, but I think if you actually raise the level of education, the research expertise, the clinical expertise of clinicians within countries, that will increase the demand on their own countries.
Professor Wendy Spearman, thank you very much. It was lovely interviewing you, and thank you for your time with us.
Thank you very much. Really enjoyable to be here. Thank you.
زي ما سمعنا، التعاون ما بين العلماء الأفارقة، التشبيك في الأبحاث اللي بتتم، التعاون مع متخذي القرار، وكذلك مع الجهات المانحة، كل دي أمور مهمة جدا لتطوير المنظومة الصحية، مش بس على مستوى الدول ولكن على مستوى القارة الإفريقية. شكرا لكم، وإزاي الصحة.